Okay, in module 3 of this lecture, we are going to turn to the conduct of the market. Specifically, we're going to look at drug pricing. Okay, so drug pricing and profitability probably generate the strongest reactions among the public and the media. I could pull up headline after headline that paint the pharmaceutical companies as exploiting patients through patents and other strategies that reduce competition. And make no mistake, many studies do show that pharmaceutical profits, at least as reported in financial statements, are consistently among the highest of all industries. And this relatively high return is often attributed to monopoly power, but the profit picture is less clear. And that's because there are some pretty big complexities of accounting for expenses and upfront R&D investment. So if you've taken healthcare finance, you probably know a little bit about this, but without trying to sort through all of the measurement nuances, it seems pretty reasonable to conclude that pharmaceutical firms earn above normal rates of return, but that their profitability has probably also been exaggerated by simple accounting comparisons. So, how do companies price drugs? True or false? For economic efficiency, should drug prices be set at marginal cost of production? I guess that's a yes or no question, the way I phrased it, but think about that. So in order to think about that question, we have to return to our trusty monopoly profit model. And I think I'm actually going to do this with Excel. Let's pull this up. Okay, so pardon the mess. You guys probably recognize this setup from the earlier part of class, but this is kind of a midterm problem as well. So here we just have a basic table looking at some of the cost and revenue elements for a monopoly firm. So recall the x-axis here is quantity, the y-axis is price, and then I've gone ahead and inputted some curves onto this graph. We've got our demand curve, which is downward sloping here in orange. And so the demand, let's suppose this is a single product at a uniform price to all buyers. The demand here is going to be negatively sloped for a few reasons. So even though patients with fixed copayments don't face higher out-of-pocket prices and will have a perfectly inelastic demand, others may have more limited coverage or no drug coverage at all. And then patients with limited or no coverage are likely going to substitute generic or over-the-counter products as the drug price increases. So we will see a downward sloping demand in the pharma market. And we're also going to see a marginal revenue curve below the demand curve. You can return to lecture 5 if you want a refresher on why that is. And I went ahead and just kind of made up some fixed cost and variable cost numbers. On the cost side in pharma, the marginal cost of manufacturing and distributing a drug is usually relatively low, about half the total cost. And then R&D costs are substantial, right? We talked about that in our first module, up to millions and millions of dollars. So here we've actually got a relatively high average total cost. And you can see why. That's driven by what I'm going to call the fixed costs of the R&D of the drug. So if our fixed costs are low, just plug in a low fixed cost, you can see that that average total cost curve drops down quite a bit. And if they're high, so let's go back to the case where they're a lot more, 15, the average total cost curve is much larger. And that's because the average total cost is taking into account both the fixed cost and the variable cost. Okay, so if this is a monopoly firm, how much is the monopolist going to produce? Well, recall our production decision is what? Where marginal cost equals marginal revenue. Okay, and so that here is this place. This is at 3 units. The marginal revenue is 3. The marginal cost is 3. We can also see that's where the marginal revenue curve intersects the marginal cost curve. But recall, the monopolist isn't going to price the product at that point, right? So the price here being 3, they're going to price all the way up to the demand curve, or the willingness to pay, and that's 9, right? So the revenue, the total revenue for this firm is going to be equal to the quantity, so 3, times the price, and the total cost is not going to be where marginal cost is. It's actually going to be all the way up to average cost. So let me just, oh, it's already there. So our economic profit is actually going to be a little bit smaller in this monopoly case as compared to the one we were looking at in lecture 5, because the average costs are much higher than the marginal cost. So remember, in lecture 3, our economic profit was the green box, and now that we have to take into account these really high R&D costs, the economic profit is this slim green box here. Now, let's find the PowerPoint again. There we go. Okay, so this is just another maybe cleaner graph that shows the same relationship that I just showed to you in the Excel sheet. Now, another thing to note is that this profit maximizing model also predicts that the difference between price and marginal cost will vary inversely with the elasticity of demand. So let's see how that works. Right, so let's take these boxes off. And I'm just going to make my demand curve a little more elastic, or sorry, inelastic. So that means I want it to be steeper. And oh, good, did I do that down here? Yes. Let's change the price. Let's make that slope much steeper. So this is a more inelastic demand. And what you can see is that also changed my marginal revenue curve, but it had no impact on my cost because I didn't change the cost of production. I only changed the demand. So what happened when my demand became more inelastic? Well, first thing that happened is I'm producing more. So I'm going to use this blue box. I'm actually, marginal revenue equals marginal cost around, I don't know, 3 3/5, 3.6. And then we price all the way up. So here's our production decision. We price all the way up to the demand curve. So I'm going to call that, I don't know, 13. And then our marginal cost and average cost stayed constant. So let me use this box here. So here are my total costs, right? Quantity times average cost. So profits are a lot larger in this situation when the demand curve is more inelastic. Also, you can see that the price differential between the price and the marginal cost is much higher, even the price and the average cost. You can see by comparison, here was the difference in our original example. Okay. And that makes intuitive sense too, right? If this is a drug that's life-saving, the pharmaceutical company can charge a lot more for that drug because the demand is more inelastic, people need it to survive, and thus they'll capture more economic profits, assuming the marginal cost was the same as in our initial example. Now, with monopoly power, pharmaceutical companies can also engage in price discrimination. And this will take an interesting form in the pharmaceutical industry. Let me explain price discrimination again. We've done this in class, but in Excel, you can see it a little more clearly. So remember, here was our initial, let me put the price back. Right. So our initial pricing or revenue curve was here, revenue box, remember quantity 3 and priced at 9 up to the demand curve. But what if the pharmaceutical company can price discriminate, meaning they can charge everybody the different price based on what they're willing to pay? So let's say instead of charging $9 for all 3 units, with this red box being again, my total cost box and this sliver being the revenue. What if the pharmaceutical company can say, hey, for the first unit, we know this person's willing to pay 15. And for the second unit, this person is willing to pay 12. And for this last unit, well, then we'll charge 3. So in this case, when the pharmaceutical company can price discriminate, they actually capture this piece's revenue, this piece's revenue, and this piece's revenue. So much higher than when the price is uniformly 9 for all 3 units. Okay, so that's kind of the logic of price discrimination, is you capture as much of that consumer surplus as possible. And this kind of price discrimination, back to the PowerPoint, is unique to the pharmaceutical market. Well, not unique, but especially prevalent in the pharmaceutical market. Now, we call it the form it takes third-degree price discrimination, which is also called market segmentation. And again, different groups of buyers are charged different prices based on the elasticity of demand. So rather than figuring out how to capture surplus here, you break the market into 2. And before the enactment of Medicare Part D drug benefit legislation, the media would routinely run news stories about Americans who would flock to Mexico where the prices were much lower to buy drugs. You'd also hear stories about people using drugs packaged for veterinary medicine because they were priced much lower than similar products packaged for human use. So what accounts for that wide variation in price? Well, one explanation is fairly straightforward. If a firm can distinguish between markets with different demand characteristics, and it also can limit arbitrage, which is the Mexico example I was talking about, where third-party resell at lower prices in higher markets, well, then the firm can increase profits by charging different prices. So assume for simplicity, my laser pointer, that the firm I just described in my Excel spreadsheet sells only in 2 places, the US and in Mexico. So what I've done here, or the book has done here, is separate the total demand into US demand and Mexican demand. Now, the demand curve, as it's shown here in the US, is more inelastic, and the demand curve is shown here in Mexico is more elastic. Why is that? Well, in the US, you have higher incomes, you have more generous insurance, and so the demand is going to be more or relatively inelastic here. Now, let's assume further, just for simplicity, that the marginal cost of production and distribution is also the same in both countries at this level, and that for now, the prices are not regulated in either market. So here again, profit maximization occurs where marginal cost equals marginal revenue. So this dot. And it's going to result in 2 different quantities, the quantity in the US and the quantity in Mexico. And even though marginal revenue is going to be equal in both countries, the price is going to be higher in the market with the more inelastic demand. So here the US, which also means that the profits are going to be higher here. And the profits are higher than would be than those obtained with uniform pricing. So you can imagine that if the price in the US was uniform to the price in Mexico, this would be our profit in the US, and this would be the profit in Mexico. So we'd lose this box up here. All right, make sense? Okay, so this isn't the only possible explanation for price differentials. Prices in some foreign countries can be lower because the government regulates the prices, or their national health plan serves as a monopsony buyer. So let's continue with this figure. Let's suppose that the Mexican government imposes some price controls. Now, conceptually, this would drive, or it could drive price as low as this marginal cost here, which would further increase the differential with the US. So let's call this price with regulation. And that would drive the price down. And basically, critics charge that by failing to control prices in a similar manner in the US, so you've got this regulation. This is what we see in the UK and the Swiss example I gave in Module 1. And the critics say that by failing to do this in the US, consumers in the US bear the burden of the development costs, and that the US actually subsidizes other countries. Now, what's wrong with that accusation? Well, it's not necessarily the case. Right? Here, a firm is just trying to squeeze out the profits where it can. It's not losing money as long as this firm is producing above marginal, or let's say average cost. The firm's still making profits. So in that sense, I don't want to say the criticism is misguided, but maybe deserves a little more nuance, right? Because it really depends on whether or not the firm is capturing the average cost, so taking into account those 14 years of R&D, covering their marginal costs. And so the idea that that Mexico, or that the US is subsidizing Mexico in terms of keeping the firm afloat, is not totally true. So we'll come back to that claim with respect to innovation in a few slides. So how does this work in practice? How are drug prices set? Well, obviously it's not as simple as one price in the US, one price in Mexico, one price in Turkey, one price in the UK. Now, this question of how prices are set is complicated by the fact that drug manufacturers sell their drugs to different purchasers, or intermediaries, who in turn sell them to patients. And drug companies don't sell to all intermediaries at the same price. And here we need to talk about pharmacy benefit managers, or PBMs, the intermediaries. So PBMs, pharmacy benefit managers, are another influential player in pharmaceutical markets, in addition to the consumer and third-party payer, health plan, physicians, manufacturers, pharmacies. In fact, more than 200 million Americans obtain their drugs through a PBM, and PBMs never physically handle the prescription drugs, but they serve only as intermediaries between health plans, between manufacturers, and between pharmacies. So how that works is that health plans pay a fee to the PBMs, and the fee paid to the PBM can be based on the number of insured individuals. It can be on a fee-for-service basis. And in return, the PBM negotiates rebates from the drug manufacturers by offering to include their products on a formulary. PBMs also arrange price discounts from pharmacies by channeling a relatively large volume of these guys, the consumers, or the patients to them, and PBMs promote generic substitution through their formularies and also through their interaction with the pharmacies. So many PBMs use lower co-payments as a financial inducement for the consumers to purchase a generic as opposed to brand name drugs. It's very complicated, it's very convoluted. It would be a lot easier if it was one price here and one price there. Now, the rapid growth in drug expenditures has led to great policy interest in cost containment. And maybe you've talked about some of these policies in your other classes. Arguably, no issue is more important to the drug policy conversation than the effects of prices on innovation, and then by implication, the effects of drug price regulation on innovation and the availability of drugs. So these efforts include, well, we're going to walk through a few, but price ceilings. So this is the idea that you basically, the government says this is the maximum amount that you can charge for this drug. The Italian government does this. They publish a list of maximum permissible prices. The UK does this as well. Now, the drawback, even though that's great, you theoretically control costs. The drawback is that you also theoretically reduce the incentive for research. So you've got this trade-off between access to existing drugs and incentives to develop new ones. Now, the US has no broad price controls. The claim that folks make is that other countries free ride on the US market for future innovation, and that drug companies count on making the biggest profits off the US consumers. So it's not that they're losing money in a different market where they're selling below marginal cost, though you could also argue that case on a drug by drug basis, but the argument instead being that the innovation is subsidized by that promise of really big profits in the US market. There's a huge literature out there on whether or not, or the extent to which this happens, and I don't have time to cover it in this lecture, but if you're interested, definitely go dig into that because it's very, very interesting. How does price control work? Well, I kind of showed this earlier. You can see this red line. It's basically where the government comes in and says, this is the price at regulation, we're cutting you off, and you basically, you still produce where marginal revenue equals marginal cost, but profits are slashed. This goes away, right? So how do you actually do that? How do you decide where to set the price if you want to come in and limit monopoly profits? Well, there's a few ways to do it. You can do external reference pricing, and this is where you basically use international price comparisons as a benchmark. So you would go look at that initial graph I showed you of Humira and say, well, in UK or Switzerland, lowest price is this, so we're not paying any more than Switzerland. You could do it internally. So internal reference pricing is when you have a third-party payer establish the reimbursement rate, and typically they do that by looking at the drug class as a whole and then the lowest price within the drug class. This is a trade-off. Price regulation lowers spending, but also theoretically reduces investment. Not even theoretically, it's just shown. It does reduce investment in research and development, in the rate of innovation, and also in the number of, should say, drug launches. In the US, we don't see these kind of price controls. We typically see other cost containment methods like higher co-payments, promotion of generic substitutes, and other managed care strategies like drug formularies. Now, there have been propositions or proposals for drug price standards or drug reference pricing. So there's a couple examples. This is California Proposition 61, was on the ballot in California in November of 2016. basically a yes vote would have required state agencies to pay no more than the VA pays for prescription drugs. So kind of like an internal US reference pricing type approach, and a no vote would oppose the measure. So how do you think the vote went? Dun, dun, dun. Well, it didn't go well. It was rejected, 54 to 46. Interestingly, more than 125 million was raised for lobbying efforts for Prop 61, with obviously the majority of that coming from drug companies that oppose it. Here's another one. This is the Ohio Drug Price Relief Act. It was in the ballot in 2017 in Ohio. What do you think happened? Overwhelmingly rejected. 80-20 vote on this one. I don't know what the lobbying was like here, but I can assume it was a lot. So with all of this in mind, what I want to do is set you all up for a conversation we're going to have in class this Wednesday. So I want to talk about Sovaldi. Now, this drug was available in 2014 from the drug manufacturer Gilead Sciences. And it's a Hep C drug, and it works really astonishingly well to cure patients who have the liver disease hepatitis C. Now, about 90% of patients are cured with only a few side effects, and it was really an enormous improvement over previous drugs for hepatitis C. What's the rub? Well, it costs almost $1,000 a day for all 12 weeks of treatment. Now, if state governments were to pay for Sovaldi, the total bill would be something like $55 billion. You can compare that to the average Medicaid spending by states last year was $10 billion. So if states were to pay the full price, that would be 5 times the entire Medicaid budget or entire Medicaid expenditures last year. So what do? Well, most state Medicaid programs sharply limit access based on your liver fibrosis stage and also the period of abstinence from drug and alcohol use. So this is a map. These two maps show different Sovaldi coverage regulations by state. This first one showing liver fibrosis stage, and the second one showing requirements for abstinence of drug and alcohol use. Now, what I want you to think through for our conversation in class is, should the government regulate the price of Sovaldi? And if so, how? Now, a few things to think through as you prepare for this conversation. You can think about, would lower prices improve health and lessen financial stress on patients and consumers? How do you weigh that possibility against potential harm on future innovation? You might want to look up what Europe's experience has been with the regulation of Sovaldi and why it's so different from the US's experience. And if not price regulation or negotiation, what else might the US do to control costs and promote access? So what I really want you to think through is, I don't want this discussion to answer the question of whether drug companies are making excessive profits, but really what I want you to do is think through the public policy trade-offs involved with each of these decisions. So with that, I will end the video. I will see you in class. We'll talk about Sovaldi, and we will also do some more examples with monopoly drug pricing. Take care.